Good morning and welcome to Surgery Grand Rounds. There is no commercial support. The speaker and planners have disclosed no relevant financial relationships with any commercial interests. You will receive a SurveyMonkey link after today's activity, and if you're viewing online, we'll enter that link into the chat section. If you are a surgeon and would like for us in GHS to report your CME credits to the American Board of Surgery, you will need to fill out the evaluation link, and it will ask for your date of birth and your board number. It is my pleasure to introduce Dr. Maurice Asouzu, who graduated from University of Alabama, Birmingham School of Medicine and is currently a chief resident within the Northeast Georgia Medical Center General Surgery Residency Program. He is part of the inaugural residency class, and he plans to continue serving our community post-graduation and will be joining Longstreet Clinic General Surgery. Join me in welcoming Dr. Asouzu.
This morning, we're going to be talking about growing pain after an inguinal hernia repair. So these are patients that return to clinic. They've had a previous hernia repair. Could be short-term, could be long-term, and they present with growing pain. And I'm going to talk through just kind of different etiologies and how to work through this. I've got no disclosures this morning. So our objectives, we're going to just highlight the significance of chronic postoperative inguinal hernia pain. What is it? The significance. We're going to define and distinguish types of pain, recognize symptoms and how to diagnose this, discuss non-surgical management options, and then just kind of review the appropriateness and timing of when and if surgery is an option. We'll start with what is it? CPIP, chronic postoperative inguinal hernia pain. We'll talk about the pathologies and different etiologies of this pain, symptoms, diagnosis. We'll talk about non-surgical management options. Briefly, just naming surgical options. The focus of this presentation is not to really focus on how to do these surgeries if surgery is indicated, just kind of how to evaluate when you need to start thinking about it. Does this patient need surgery? And just a general approach to the outpatient referral, somebody that presents to you in clinic. So chronic postoperative inguinal pain. It's defined as postoperative pain lasting at least 3 months after surgery. This 3 months kind of gives the patient time to get over the acute inflammatory period when the inflammation around the mesh has subsided, but they continue to have pain. Its significance, globally, there are millions of growing hernia repairs, inguinal hernia repairs done every year. It's been quoted as many as 8 to 16% of these patients can experience this chronic pain. And this chronic pain can be debilitating. It can be to the point where it's impacting their daily lives, especially hard workers that do a lot of lifting and straining and squatting. And it can be debilitating and cause them to lose days at work. So it's a very important clinical problem. I'll start with just a couple of definitions of pain. You've got nociceptive pain versus neuropathic pain. Your nociceptive pain is just the acute pain, just secondary to the inflammation after surgery. Key about this pain is it should lessen over kind of a predictive period of time. We all kind of know the general postoperative course of a hernia. The pain should get better further out from surgery. And if it doesn't, then you need to start thinking, is this neuropathic pain? This is due to abnormal neuroactivity, and this can persist without any ongoing inflammation. So this is kind of your chronic nerve-like shooting, burning pain that patients can have months later. I'm going to just kind of one at a time go through the etiologies of this chronic postoperative inguinal pain. Things we need to kind of be thinking about, is there recurrent hernia, is this nerve-related pain, mesh-related pain, testicular ischemia can be a cause. You have to rule out that they don't have an infection of the mesh, and is it something totally different? I'm going to kind of touch on what a sports hernia is. So recurrent hernia. Timing, this can be early versus acute. So you can have early recurrences, within a month or a couple months after your surgery. And it can be occult, meaning they can come and, they don't always present with a huge lump. It can have a recurrence of their hernia that you may not feel. When to suspect. So a lot of times you'll suspect this when there's a gap between the repair and the new pain. So you do the hernia repair. They're like, I'm great, doc. Feel so much better. And they come back a few months later with the same symptoms that they presented with initially, same pain. Sometimes they may even have a bulge. How to diagnose this? First thing, exam. I mean, if you examine them and you go, go in external ring and you have them call for whatever your general hernia exam is, and you feel a bulge or you feel a direct bulge there, you made your diagnosis. You can stop there. The hernia has recurred and fix it, Also, you can do a standing Valsalva inguinal ultrasound. Just like all other ultrasounds, this is user specific. So it's got to be somebody that's familiar with doing these types of ultrasounds, having them Valsalva and filling for a lump as you're looking with an ultrasound. Same thing with a CT. You can have them Valsalva during a CT exam, and it'll make the hernia prominent. Or you can do an MRI, which is not user specific, and you'll see the hernia or not. It's a very sensitive test for seeing if there's a hernia. To the right, I've got an image of this is that Valsalva ultrasound. So on the left side, you can see there's a bulge below the abdominal wall there. After they Valsalva, you can see that bulge comes above the abdominal wall, and H is marking the hernia that they have. So treatment for that, I'll go back. Treatment, fix the hernia if they have a recurrent hernia. Open versus laparoscopic, whatever the surgeon's preference is, but fix the hernia. A lot of times, if a hernia fills one way, a lot of times you'll go in a different plane to do the repair. But that's how you would fix that. Nerve-related pain, it can be acute versus long-term. By acute, you can have a patient that wakes up from surgery in excruciating burning pain. This pain, or you can have long-term. It can be months later and they start having this burning, shooting. It's described as kind of burning, shooting pain, stabbing pain. And the thing about nerve-related pain is it's usually in the known anatomic distribution of the nerve. I'll kind of briefly just talk about the nerves. These are the nerves involved within the inguinal hernia. Iliohypogastric nerve is usually T12 through L1 nerve roots, 2 centimeters medial and 1 centimeter inferior to the ASIS. And it's usually located between external oblique aponeurosis and underlying internal oblique. That's where you'll find the nerve. Innervation, it usually innervates the skin in the suprapubic area and then around to the upper part of the thigh and the buttock. The ilioinguinal nerve, T12 through L1 nerve roots. It's usually 3 centimeters medial and then 4 centimeters inferior to the ASIS. And then it emerges lateral to the inguinal ring, and it travels toward the external ring down the inguinal canal. Accompanies the spermatic cord. Innervation of the ilioinguinal nerve, proximal and medial thigh, the mons pubis, the labia majora in females, and then the roof of the penis and the upper scrotum in men. These innervations are important. I'll talk about it later, how you can kind of map out and they determine kind of which nerve can be causing their pain. The genital branch of the genitofemoral. L1, L2 nerve roots usually runs down on the psoas muscle, runs through the inguinal canal on the anterior surface of the spermatic cord, and its innervation is going to be your mons pubis, labia / scrotum, and it also provides innervation for the cremaster muscle. And the graphics on the right of the screen kind of show the routes of these nerves I'm describing. So you can see most of them are lateral, and then travel down inguinal canal. Lateral femoral cutaneous, L2, L3 nerve roots. It passes underneath the inguinal ligament, approximately 2 centimeters medial to the ASIS, and its innervation is going to be the anterior lateral thigh. This is a graphic that I like because it kind of maps out kind of when you see a patient in clinic. These are kind of be the areas you're going to be examining and trying to map out where their nerve pain is coming from or which nerve may be associated with the pain. Each one is, each nerve is kind of outlined there in the colors based on the innervations that I previously described. Only one that's not shown here is the lateral femoral cutaneous, which is going to be the anterior lateral thigh. And then just kind of a laparoscopic view of the inguinal anatomy. You can see your triangle of pain there is lateral. So a lot of, when you're doing laparoscopic hernia repairs, if you're too far lateral in that triangle of pain there, that's kind of when you're going to get into trouble as far as involving these nerves and causing this chronic postoperative inguinal hernia pain. Put in tacks or sutures or even dissecting in the wrong area can injure these nerves or cause this postoperative pain. There's primary and there's secondary nerve injuries. You can have a primary injury where you have a complete, partial transection of the nerve. This can lead to a neuroma, which is just a chronic nerve injury. You can have nerve damage related to manipulation, so stretching, crushing, cautery injury, and this kind of goes for both laparoscopic and open hernia repairs. And an open repair, if you're retracting the ilioinguinal nerve out of the way, you can cause a stretch injury to it. Entrapment or impalement by sutures or staples or tacks. So that's kind of putting tacks and sutures in areas where they shouldn't be. Secondary injury is just when the inflammatory process adjacent to the nerve causes this chronic pain. It can be incited by the mesh, just kind of inflammation surrounded by the mesh taken. So those are kind of the two divisions, primary, secondary. Diagnosis. So acutely in the postoperative period, you can have, it can be instances where a patient wakes up in the PACU and is having excruciating pain. In that case, you need to take them back to surgery and take a look, because a lot of times that can mean you put a tack or something in an area where it shouldn't be. And usually this pain is going to be different than the pain that they had before surgery. It's going to be kind of that acute burning pain and the distribution of a nerve. But this pain will be different than what they had before surgery. So that should kind of ring some bells that you need to take a look. Chronic, there's chronic pain, ways to evaluate that. There's this Tenel sign. And that's where you kind of palpate there next to the ASIS. It's going to kind of tease out ilioinguinal, iliohypogastric pain, because you're palpating kind of in the distribution of those nerves, and they're going to say they have shooting pain in those areas of innervation. There's also different maneuvers. You can have them flex the groin, flex the hip. There are different maneuvers that can kind of tease out this pain. And you can do mapping of these areas. When I say mapping, you actually have them in clinic, and there are a lot of surgeons that will actually, they'll take a marker and they'll put pluses in areas where there's pain and negatives where there's no pain, and kind of map out where the pain is, and then look at kind of the distribution of where the nerves are and kind of map out exactly what nerves may be involved. And this kind of comes into play when you're treating them as well. You can kind of map out their pain initially if you want to send them home on NSAID, Celebrex, things like that. Physical therapy, of course. See if their pain gets better, bring them back in, map it out again, and see what's changed. So that's kind of one way that this nerve pain is kind of teased out. And then another way to diagnose, not only diagnose, but this will also be part of the treatment plan, is nerve blocks. So long-acting anesthetics, local anesthetic plus steroids. A lot of times it can be 5 to 10 mils of bupivacaine, you can use lidocaine, and then usually it's mixed with like hydrocortisone or some kind of steroid. And then the reason I put this in diagnosis is, initially if you block the innervation of certain nerves and their pain gets better, that kind of can help you figure out, okay, I've blocked the ilioinguinal, I've blocked iliohypogastric, your pain got better. So it just kind of helps you map out initially what nerve distribution may be causing their pain by deadening the pain. And these are just some pictures I found that were pretty helpful. I like the way they kind of show the ultrasound view. All these nerve blocks are done under ultrasound guidance. You can actually see whether the nerves run on ultrasound. And of course, this would be an experienced ultrasound user. Usually these patients, there are surgeons that are kind of specialized in working this type pain up, and they're used to doing these kind of ultrasounds, or you send them to like a pain clinic, and an anesthesiologist would be doing this. Someone who knows these planes is actually tailored to where you inject right to this plane where the nerve runs, and let the local and steroid just kind of run in that plane. Interesting, I saw when I was reading, it used to be that they just palpate the ASIS and you just go 2 centimeters medial and inferior and just inject local into that space and see if the patient gets better. But with ultrasound, and now it's kind of a more tailored approach where you can actually look for the exact distribution of the nerves and inject right in that area and see if they get better. The general femoral block, it runs along the cord, so you're really blocking the cord. Only thing with this is these nerve blocks, especially if you're doing like a laparoscopic repair. What I mean by the pathology may be proximal to the block. Say we're blocking the groin, but the nerve injury is higher up, along the psoas or something, or higher up, proximal to where the block's being done. They may not feel that relief, so it may be hit or miss when you're doing the block. Nerve-related pain treatment. So initial management, you can try them on things like gabapentin, pregabalin, duloxetine, ibuprofen. So just medications and NSAIDs along with these other medications to see if it helps with their pain. You can do nerve blocks, treat them with an initial injection, see if it helps their pain. And then you can do weekly injections to try to see if you can break this pain cycle. And sometimes you're done there. You do a few injections or pain, you kind of break that cycle of pain, and you're done there. Nerve ablation is also an option. So you can use a neurolytic solution such as phenol alcohol, and it's injected to kind of permanently destroy those nerve endings. And a lot of times this can help their pain. And then if none of this works, you can look at doing surgery. Like I said, I'm just kind of touching on what the surgery would be, but I'm not going to get into the details of it. These surgeries are usually performed by, groin pain or hernia specialist. Same thing with the nerve blocks and the nerve ablations. A lot of specialized hernia centers, the surgeons themselves can perform these blocks because, they've done them, they're experienced in them. A lot of the time, these nerve blocks are going to be done after you refer somebody to like a pain clinic after the initial management has failed. Surgery would involve a single versus double versus triple neurectomy. So the aloinguinal, alohypogastric genitofemoral nerve actually going in and resecting a portion of these nerves. And it can be done open versus robotic. Like I said, I'm not going to get into details of it. Basically, you go in, these nerves identified, and you resect a portion of these nerves. This was an interesting study I found. It's called the Groin Pain Trial. And it was a randomized controlled trial at a single center from 06 to 13. So they had 54 patients with chronic neuropathic pain after a primary open repair with mesh, Liechtenstein repair, and greater than 50% of pain reduction after a diagnostic TPI. Tender point infiltration is talking about injecting with local anesthetic, and their pain, greater than 50% of their pain got better after the initial injection. So these are patients where they did an initial nerve block and the nerve block helped. So they kind of helped them know that, hey, this is neuropathic related pain. These are the patients that were involved in this study. They were randomized for repeat nerve blocks with lidocaine, a steroid, and hyaluronic acid. The hyaluronic acid, I looked it up, it kind of just helps with pliability of the skin, helps keep the area, moisturize the skin, hydrate the skin, Hyaluronic acid is often used in like osteoarthritis blocks as well. Helps with just kind of moisturizing the joint and helping. Versus neurectomy. And primary outcome is if greater than 50%, you have a greater than 50% pain reduction using the visual analog scale. This is a scale that's used, is 0 to 100. They're sent questionnaires at 3 months and 6 months, and it's just, how's your pain? Like they're asking them questions related to their pain and activity, and it's a scale. So wherever they land on that scale. But the goal is, did these patients have a greater than 50% reduction in this scale after 6 months after the treatment that they were enrolled into? Results, so the nerve blocks, the TPIs, were successful in 22% of patients. Neurectomy was successful in 71% of patients. And then there were 19 patients that actually crossed over into the neurectomy group after an unsuccessful nerve block. Their score dropped from 60 to 14 points. So you get that greater than 50% reduction. And the conclusion that this study came to was that tailored neurectomy is 3 times more effective than a nerve block in chronic inguinal hernia pain after an anterior mesh repair. But I found it interesting that you still need to do a step up approach. So you're still going to start with nerve blocks, followed by a tailored neurectomy. When they say tailored, that's when you've done your mapping and you map out which nerves may be involved, and you do kind of a tailored approach where you resect those nerves. But neurectomy was proven to be more effective in this study, but you still would manage it the same way by starting with a stepped-up approach. So you would do your nerve blocks, start with your initial management of even before the nerve blocks, putting on NSAIDs, physical therapy, things like that, see if they get better. And the last resort, surgery is still going to be your last resort. So next, we can touch on mesh-related pain. So location, usually this pain is going to be in the distribution of your mesh. Can be at the pubic tubercle. A lot of times is where they're going to say they have pain. And then your neuropathy, your neuropathic pain is absent. It's kind of point tenderness, kind of right where the mesh is. You can do your exam where you go an external canal and press right there where the mesh is laying, and they'll say, ouch, that hurts right there. So diagnosis is on physical exam. You have to rule out, of course, that they don't have an occult hernia, so make sure they don't have a recurrent hernia there. And then you've got to rule out mesh infection. So we all know how we rule out infection, if it's red, inflamed, point tenderness associated with, if they've run fevers, any kind of drainage, skin changes. So you have to rule that out. Treatment, initially, pain clinic, you can do means such as massage therapy, ultrasound therapy, where they use sound waves to kind of break up the scar tissue in that area, physical therapy. If these means fail, they fail all these pain management methods. You've had them on, of course, you have them on NSAIDs, things like that. Another thing you want to look at is, does this pain limit their activities of, before you take somebody back and do reoperative surgery in this previously operated field, is this your 80-year-old patient that's kind of laying around the house most of the day and, not really that active? Can you manage them with these non-surgical means and their pain is tolerable? Versus is this your worker that's, doing construction or doing something where they're active every day and it's just kind of debilitating them? If that's the case, then you have to, you would look into doing surgery on them if this pain doesn't improve. Surgical principles, always want to try to get a previous op note, see what kind of repair was done. Was it open? Was it laparoscopic? Was it robotic? Remove the mesh. And I found this interesting. A lot of, it's kind of controversial. Different surgeons take different approaches, but you remove the mesh, and if you see any nerves, you perform a neurectomy. I read some articles where some surgeons just remove the mesh and don't touch the nerves, but other papers, said if you see the nerves, do a neurectomy, just because you can't 100% rule out that they weren't having pain from these nerves. And then don't place more mesh. So you do some kind of tissue repair, whether it's a Bassini, a McVeigh, one of these tissue repairs. Next thing I wanted to touch on was testicular ischemia. So it's a type of chronic orcalgia or testicular pain. It's very uncommon, but it can happen. Usually it can be caused by dividing the cord or blood vessels, which that's pretty dramatic. Of course, you want to protect the cord and not divide it. Or you can have kind of a coagulating or thermal injury to the blood vessels surrounding the cord. You have a high risk of this after repeat repairs, just because there's a lot of scar tissue. It's the reoperative space, so it's something that can be associated with recurrent hernias. Diagnosis, you can get, usually these patients will have pain in the testicle only, so they'll have testicular pain. And then you can get an ultrasound of the testicles, get a scrotal ultrasound and look for blood flow in the testicles. I found this graphic here on the left. You can see that there is blood flow to this testicle. And it's compared to the left testicle where there's no blood flow. So that's kind of what you'd see if you're concerned for testicular ischemia. You'd see no blood flow to that testicle on ultrasound. Treatment. This is where you want to get urology involved a lot of times. They can do what's called a robotic spermatic cord denervation. This can also be done via microsurgery. That's basically where they go in there and actually denervate the spermatic cord, so that the small nerves that run along the cord, they actually denervate those. Another thing they can do is you can just let the testicle involute. So, this is just leaving them alone. The testicle will involute if it's not having blood flow, if it's truly ischemic. You do have to check their testosterone levels, though, because you may have to supplement that if the testicle actually does involute. Or you can do an orchiectomy. Those are kind of the treatment options that urology looks at. Like I said, not a urologist, but these are some of the treatment options that urology looks into when a patient gets referred to them for this problem. Mesh infection. This is also something we have to rule out. So pain associated in the area of the mesh. They can have draining sinuses. You look for signs of any other infection. Do they have erythema? Do they have induration? Do they have a draining sinus? You would get imaging if they have you get a CT scan. If they have a fluid collection near the mesh, it could be a seroma. But if they have, like I said, if they have other signs of infection, then you have to be thinking: is this an abscess? Is this infection of the mesh? And you take that into play with your physical exam. In treatment, it's going to be to remove the mesh. And then, like I said, like you want to look at doing a tissue repair, and I put mesh back in this infected field here. Is it something else? So this is where I kind of want to touch on a sports hernia. They've heard of a sports hernia before. So sports hernia, they're also known as sports-related hernias. So this is where a patient presents and has persistent unilateral pain in the groin without any hernia present. And to diagnose somebody with a sports hernia, you also have to rule out that they're not having any kind of underlying GI or GU conditions that might account for these pain or symptoms. Usually you see this in a lot of times they call it sports hernias. You see it in athletes a lot of times. It's from chronic repetitive trauma or stress to this musculotendinous portion of the groin. I have a graphic up there on the right upper quadrant of the screen up there. It kind of shows the area, just a lot of stress in that area, overuse of these lower abdominal musculature, the rectus abdominis, muscles of the upper thigh, the adductors. Just overuse of these muscles causes kind of this shearing type injury that causes this pain, and it's usually kind of right there at the pubis. Symptoms: localized tenderness at the pubic tubercle at the insertion of the conjoint tendon. They can have tenderness over the deep inguinal ring. They can have dilation or pain at the external inguinal ring without an obvious hernia. Tenderness at the origin of the adductor longus tendon. You'll see this a lot in patients that do a lot of acceleration from a typical sports position, so like football players, hockey players, rugby, patients that are kind of pushing up using these adductor longus muscles frequently. And they'll say they have just kind of diffuse pain throughout the groin or the inner thigh. And then you evaluate them, of course. You don't palpate a hernia. A lot of times you've done imaging by that time and ruled out that they don't have a hernia, an obvious hernia in that area, like an inguinal hernia. Treatment for this, most of these patients are treated without any kind of surgery. NSAID, rest. I know it's probably hard telling a high school student or an athlete that need to rest, but really you have to give them a trial of just NSAIDs and rest, and then coordinate that with some physical therapy. And a lot of times this sports hernia related pain from this kind of stress injury will get better on its own and doesn't require anything further. Wanted to touch on a general approach to the outpatient referral. So we've kind of gone over all the different etiologies, what it could be, what it might not be, how to kind of evaluate these typical different etiologies. And now we're going to just kind of touch on, the patient that's had a previous hernia repair, sees you in clinic, says, "Hey, doc, I'm having pain. I've had this thing fixed before. What's going on?" So at the beginning of the encounter, you want to set expectations. You want to tell them, our goal is going to be to provide you some kind of plan going forward. We're going to try to figure out some kind of treatment plan. I don't really know what's going on with you right now, what's causing this pain, but we're going to, in a stepwise fashion, evaluate this. And your goal of the encounter should be, you may reach a diagnosis during that first encounter. You may palpate the area, examine them, and say, "Oh, your hernia is back, needs to be fixed." You got your diagnosis. It may require some further testing. You may have to get some imaging or to further work this up. And then, if you've gone down different routes, you've seen them a couple times, methods have failed, you may have to refer them to a specialist that deals with growing pain very frequently. If you're assuming the patient's had a previous hernia repair, you want to try to get their previous operative report so you can look and see what type of hernia it was, what type of repair they had. Was it open, robotic, laparoscopic? A lot of times you can look at their incisions and get an idea of what was done, but a lot of patients don't know how their hernia was fixed. They just say, "Hey, doc, I had my hernia fixed 10 years ago." So it's kind of important to get this operative report so you can look at what's been done. Were any nerves sacrificed or preserved? Were there any complications? And was this a patient that developed some kind of complication or seroma or something after surgery, had to have it drained, or any kind of complication or hematoma associated with the surgery? Get that information to give yourself all of the picture. Get a good history, timing. Was it, did this happen acutely? Did they come from north side? They got pain now. Or was there a pain-free interval? It got better, and now they're having the same pain they had before their hernia was fixed. Get a description of the pain. Is this shooting, burning, stabbing pain? Does this sound like neuropathic pain? Is it in the distribution of a nerve? Is it in the location of the mesh? So kind of the same questions to kind of tease out some of these different etiologies. Get their associated symptoms. Did they say, hey, doc, I have a huge lump on my right side, right where I had my previous hernia before? That kind of gives you an idea. Ooh, is this a recurrence? Do they have redness and swelling? Is it warm? Is it tender? Is there draining sinus? Are there skin changes? Signs of infection. You want to make sure you get all of this from the history. Do a good physical exam. Palpate them. Do a good exam for a hernia. Make sure it's not a recurrent hernia. Assess their pain. So map out the area. A lot of patients, like I said, a lot of surgeons like to actually draw on the groin and kind of map out what nerves may be associated. Make them do hip flexion, adduction, abduction, flex the rectus, extension. Make sure they don't have what sound. This is your 25-year-old playing football or something like that. College athlete. Tease out, could this be a sports hernia? General approach to treatment. So initially, you can trial them on just anti-inflammatories, NSAIDs, Celebrex, different PO medications for about 6 weeks, and rest. You have to tell them that they have to rest. You can't have them doing the same activities that are aggravating their pain. Have them rest. NSAIDs, 50% of these patients will actually get better with just rest and NSAIDs. But if they come back and they're still having pain after rest and, kind of these PO medication route, get some imaging. You can do the valsalva ultrasound, testicular ultrasound, rule out testicular ischemia, involvement of the testicle if they're having pain down in the scrotum at the testicle. Or you can do an MRI of the pelvis. That'll look at them for any kind of recurrent hernia, very, very sensitive test. Can try the nerve blocks. So, of course, they're ultrasound guided. Like I said before, some surgeons are comfortable performing these blocks in distribution of the ASIS, depending on where the nerve's located. Other surgeons are not as comfortable performing these blocks, so this is where you refer them to a pain clinic or to a hernia specialist or groin pain specialist center that deals with this frequently. And they'll try nerve blocks. Use these nerve blocks. It'll get relief for 8 hours, several days. Then they'll have them follow up in 1 to 2 weeks. Ask them, did the pain get better? Did the pain recur? If it did, when did it recur? And then if they had, say they had relief from the injection, you can do recurrent injections. You can do an injection every 1 or 2 weeks. And sometimes these injections alone will kind of break this pain cycle, and the patient will get better, and they'll come back and say, my pain's gone now, and you can stop there. But if they continue to have this pain, it's, unless you're very experienced and, this working up this growing pain and management, this is the time where you should kind of discuss, should I refer them to somebody that deals with this more frequently? So referral to a specialist, somebody that deals with growing pain. Everything's very subspecialized nowadays. So there are hernia centers where they have surgeons that just kind of deal with this chronic postoperative inguinal pain. So don't hesitate to refer them to a specialist who will, look at his surgeries, doing a neurectomy, an option. This is a patient that would benefit from that. So that's kind of the general approach. And this is just kind of, I found this table here that kind of talks about everything I just talked about during that kind of clinic visit. Just kind of an algorithm for just kind of working it up. Get information, start basal analgesics, NSAIDs. On this, they have early referral. If you're not really comfortable working up this growing pain and you can't find any obvious problems on your initial exam, maybe you get some imaging and don't find anything, don't hesitate to refer them to kind of a centralized expertise center that deals with, like a hernia specialist center. Get pain specialists involved, so they can try these nerve blocks. Try the nerve blocks, see if they get better. And then when all else fails, by this time you've referred them to a specialist, and they'll be evaluated for, would they benefit from a neurectomy if this really is neuropathic pain, assuming that we've ruled out all other causes of this pain. So that's kind of a general approach to just, when you have your patient arrive with chronic postoperative inguinal pain, the things to look out for, ways to evaluate it, make sure they don't have a recurrent hernia, rule out all these other etiologies, and go from there, and then kind of your general management of it. Any questions? My reference.
Oh, hold on. Thank you, Dr. Asouzu. Excellent.
I guess one of my questions is, well, first of all, note to everybody, when you're doing a hernia on somebody, maybe not an emergency one that's coming in and incarcerating, you have to fix it. If you've got an elective patient, make sure you tell them there's a 10 to 15% incidence of chronic groin pain afterwards. That's pretty high.
Right.
That's like, 1 to 2 out of every, 10 patients that you're doing. So that's something they really need to know about.
Right.
The other thing, is there an increase in this since we started doing a lot of mesh stuff as opposed to just the plain old opens without mesh? I mean, when I was a kid, I don't remember seeing all this stuff when we didn't have mesh. I wonder how much of it is due to that.
Not necessarily. Of course, we're doing way more robotics and laparoscopic than open. A lot of the data I found was actually focused on open repairs. So I do feel like in my research, looking at papers, I do feel like there needs to be more and more a deeper dive into looking at patients that have had these robotic and laparoscopic repairs. But the incidence of when mesh started being used, initially there were problems with the mesh because it was, now we use a lightweight mesh. Before it wasn't a light, it was a heavier mesh that's being used, but that's also been looked into, and using a lightweight polypropylene mesh has shown a benefit from using the heavier weight mesh. So now I wouldn't say that the mesh has caused an uptick now that we figured out that using this lighter weight mesh is the way to go. Initially, probably yes, when the heavier weight mesh was being used, but that was research and study that lighter weight mesh is the way to go. So, I wouldn't tell a patient, we're using mesh, you have a higher incidence of having chronic pain because we are using mesh. I wouldn't necessarily say that. Because, the types of mesh we use has been studied pretty heavily.
And you're reading about neurectomies. Was there any consideration for sterility if you were to take the genital femoral branch out with chronic pain, just since it controls the cremaster muscles?
I didn't see anything about it. You're talking about would it sterilize them by doing that?
Correct.
I didn't see anything about it causing sterility. I would assume that wouldn't be an issue, or if it was, that that'd be a discussion before any of that was done. But I didn't see that would cause any sterility when I was in my reading.
Excellent. Thank you, Dr. Asouzu.
Right. Thank you.